And these are our objectives for the day. We're going to cover a lot from health professional shortage areas, identifying partners that will be able to assist with PSC initiatives to combat the barriers and issues we encounter with our workforce, and understand how to incorporate these kinds of objectives into cancer plans. So before we get into today's content, I just wanted to give you a reminder about some of the resources that the GW TAP program offers you. Everything is on our website, cancercontroltap.org, and of course, we will provide the link in the resources that we send out after today's call. But on our Comp Cancer Basics page, which as you can see is one of the menu options right at the top of the web page, we list the upcoming nationally recognized monthly topics, so you don't have to scramble looking for them every month. And as you can see, if you go to the Comp Cancer Basics page, and you can select National Cancer Awareness Months list right there. Very easy for you. And as many of you know, we also offer several very easy to use cancer awareness toolkits. So National Cancer Survivorship Month is coming up in June, and we just happen to have a toolkit that your program can tap into for CDC reviewed and approved content. And you can download single images from the toolkit, or you can download whole files, so you can easily plan your whole month social media content.
Oh, hey Lisa, can I jump in real quick with one thing? Okay, it's a bonus. This is bonus, guys. Lisa didn't even know I was going to do this, so I apologize. You know I love to do that to you. Actually, just today we were able to update and address a really exciting thing that has just come out that affects us all, and that's at-home HPV screening. So the FDA just made that approval a couple Fridays ago, and if your program hasn't done any messaging with it yet, that's okay. This is a very new, uncharted screening territory, and it's a very limited offering of what is FDA approved. So, to help you guys out, GW has preemptively designed some graphics and some messages that really clarify what that FDA approval means. We don't say what it doesn't mean, but read between the lines for your programs. We do specifically have a message that says this does not replace your annual screening exam. So, you can go to that link. We've embedded these new message sets into our cervical cancer awareness toolkit. We're going to also embed it in our HPV and gynecological cancer toolkits. We're just actively working on that today. So enjoy those message sets if it helps you out to identify some messaging opportunities in that early FDA approval. Sorry, Lisa, back to you.
No, no worries. Thank you. And Kelly, just jump on in there. The other thing we wanted to mention today is our cancer survivorship learning series. You know, we all know that primary care providers play a critical role in providing follow-up care for cancer survivors. And this free course, which we offer because we know how valuable primary care providers are in the cancer continuum, can be used by clinicians to learn more about caring for survivors of adult onset cancers. So this is a series of 10 online education models, all free and self-paced. And we wanted to mention this to ensure that your clinical partners and coalition members are aware of the training. And you could, share this with any PCs who are members of your coalition, just as one example. Okay, so we're going to start moving into the substance for today. We did want to go over just a few definitions first, which our panelist today, Dr. Anushree Vachari, will talk more about in a few minutes. But just to review, three main things we'll talk about: health professional shortage areas. As the name implies, there's a shortage of healthcare providers. But this could be in a geographic area, within a population, or within a facility. We are also going to talk a bit about safety net hospitals, which are defined as providers that deliver a significant level of healthcare and other needed services to uninsured, Medicaid, or other vulnerable patients. And finally, FQHCs, federally qualified healthcare centers, are outpatient clinics that qualify for specific reimbursement under Medicaid and Medicare. And those are automatically designated as healthcare professional shortage areas. We have these links on the resource slide at the end of the presentation, and we'll again be including them in the follow-up email that we send out. Another concept that we want to, again, just provide some context for is Project ECHO. ECHO stands for Extension of Community Healthcare Outcomes. So you might have heard the term ECHO, but we have representatives here from the Partnership to Reduce Cancer in Rhode Island who are going to be talking a little bit later about their use of a Project ECHO up in Rhode Island. So we just want to give you some basic information. This is a model using a hub and spoke knowledge sharing. So the hub being a specialist team that is located remotely from the rest of the participants. Knowledge goes back and forth both ways, from the specialists to the folks out in the field, often in rural areas. And information is exchanged both ways. Staff at the Comprehensive Cancer Control Program sites have worked with various partners to conduct telementoring sessions with teams across the country. And these are done obviously using video conferencing since it's remote. And it's a method of increasing local workforce capacity, which is why we are going to be talking about Project ECHO today. And we wanted to for sure let you know about the ECHO website, because you can actually search their site for their training locations using their interactive dashboard, searching for super hubs. And it doesn't really matter where in the country it's located because it is a remote situation. I do just want to mention, though, that CDC conducted a pilot study to reduce health inequities experienced by rural cancer survivors using this model. And 4 cancer program sites in Kansas, Montana, Nevada, and South Carolina were funded to implement Project ECHO and engage patient navigators. So again, that link will be at the end in the resources, so you can take a look at their success stories. So at this point, we're going to introduce our speakers today and our reps who are going to provide some examples for us. We're going to go a little bit out of order, but first I do want to introduce Dr. Anushree Vachare, who is an assistant professor in the Department of Health and Policy and Management, and she's also affiliated with the Fitzhugh-Mullen Institute for Health Workforce Equity at the Milken Institute School of Public Health right here at GW. Dr. Vachare has a PhD in healthcare policy and research, and she's a primary care physician. Her research is focused on investigating how Medicaid policies affect healthcare access, utilization, and health outcomes among low-income populations, with a particular focus on the role of health workforce. In her current role, Dr. Vachare serves as an investigator on a portfolio of extramural funded projects that examine how health workforces composition, diversity, and distribution impact access to care and quality of care for Medicaid beneficiaries, including a focus on cancer care. We're also going to be talking today with Andy Dwyer, who is the program director of the University of Colorado Cancer Center and the Colorado Cancer Screening Program, and she is also the associate director for the Rady Family Foundation Center for Esophageal Cancer. Andy is an advisor to Fight Colorectal Cancer, a national nonprofit, in their health promotion and in their health promotion and research. In her role at UCCC, Andy directs statewide screening interventions and serves as co-investigator on various practice-based research and implementation science initiatives. She also serves as the chair for the American Cancer Society National Navigation Roundtable, and she's on the board of trustees for AONN+. Next, we have Megan Daniels, who's the executive director of the Partnership to Reduce Cancer in Rhode Island, and she has served in this role since 2021. She completed her undergraduate studies at Roger Williams University, earning her bachelor's degree in biology. Megan joined PRCRI as a rising senior and was brought on full-time after graduating in 2020. She's responsible for managing the organization's day-to-day operations, performing executive duties, and overseeing program implementation. And her partner here, Sarah Gingrich, is the coalition coordinator and PSE specialist at the Partnership to Reduce Cancer in Rhode Island, positions that she has held since January of last year. She earned her bachelor's degree in human development and family studies from Penn State University and has worked in the nonprofit sector since her undergrad years. Her experience includes supporting underserved communities and advancing public health efforts focused on equity and access to care. So first today, we are going to be speaking with Andy. And I can't see the whole audience. Is Andy online with us?
I am. Hi.
Terrific. Hi, Andy. Thank you so much. I know you have an extremely busy day, so we do appreciate your joining us. Thank you.
Absolutely.
Yeah, I'm going to stop sharing my screen so we can see you. Okay. Okay, Andy. So we asked you here today to talk about Colorado's great work in the patient navigation sphere. Do you just want to start off by giving us just a brief, summary of what's happening there?
Yeah, absolutely. So I can say that, I think our claim to fame, and one of them is Dr. Linda Burhan-Stepanoff, that I think with Dr. Freeman at the time was looking with Native Sisters and Dr. Freeman's work, we're really starting to help talk about that role and function of extension of community health work navigation. And so I will have to say that many of the folks that I've worked with are mentors that are really kind of pioneers in the field. So it's been amazing to have that. I think in Colorado, a lot of the work that we have done have bridged the community health worker navigation area, as well as looking at promotores de salud with, really a large Hispanic population in the state. So, I think in terms of growing the workforce and doing the work, we have a statewide alliance that's dedicated to all navigators, community health workers, and promotores. We've been very engaged in a lot of the navigation oncology work. And we were one of the sites at University of Colorado and Denver Health that were in the patient navigation research program. And I think with those pieces, as well as a lot of the training that was set up that I think has really helped inform part of the GW work and the like, it's been 20 years, right, of great foundation and really a long time of work. And so I think there's probably folks on the phone that I know that we've gone through training or training programs together or a lot of facilitated discussions. And so I just want to say hi. I can't see everyone as well. But I do think, the discussion around rural, right, and really thinking about access to care, in the West, of course, I think, the person was speaking before, or you were speaking about introducing the echo, we're kind of vast land masses, right? But we have about 80% who live on the Front Range. And then in the rural areas, 15, 20, 30% of the population. So, we spend a lot of time really thinking about primary care, connections to equity, really thinking about bridging to GI centers, looking at cancer treatment centers, and really thinking about how do we support the network at large. And a lot of that is done through, our coalition building, our state comp cancer work, our statewide connections, really thinking with also then AONN, ACS, and really kind of patchwork of everyone rowing together to make sure the services are working. And so I think it's been a lot of collaboration. And I would say that, one of the overarching opportunities is working with our state cancer CDPHE, our state health department, and our Comp Cancer and our Cancer Coalition, and that's been a really great thing. So, I think it's been a lot of years. I think we've also been exceptionally building off, again, lessons learned from 5 to 10 states who've been very successful in looking at Medicaid reimbursement and thinking about implementation of the sustainability. And so that's something that we're really growing out as well. But I will tell you a keen eye towards making sure that our rural and frontier communities are really at the cornerstone. And, I'm from a town of 800 people, right? It's largely cattle, it's ranching, it's farming. And so this is really, near and dear to my heart because there's not a sale barn in Eastern Colorado or Western Slope that I haven't visited. And, really, that's where my family are from. And that's where a lot of the vitality happens. And it's been a really big part of that work and something we're really keen towards paying attention to in Colorado.
Andy, I just have to comment. Would it be bad if we just started offering prostate screenings and, free screenings in those sale barns? If anyone could do it,
I think that
I
is
think you
a
can do it.
that is a fantastic idea. And I can tell you a couple of people that I would definitely go first and foremost. But what's funny that you say that though, like in terms of thinking about the work in Colorado and if there's things, that I can expressly speak about. Um, I will say that some of our participatory research around navigation and, kind of really thinking about building capacity has built on, community champions telling the story, that access opportunity, also then really talking about, we've done things that look like, sale bills. So when people do farm implement or auctions, and had people duped into looking at the materials to realize that it's health materials about prevention, early detection, kind of doing that things. We do host coffees. We've tried to hit up, grain elevators and the like. But I will tell you, one of the things that we've tried to do really keenly is also working like with Comp Cancer and our state cancer plan, right? Is building off of these examples, really trying to make sure for all parts of the cancer continuum. How are we building in navigation? How are we talking about role, developing the role and function? And then particularly for targeted communities, rural being one of those, making sure that in those processes, we're really doing that work. And some of it's built off the research, but I think we're really quite facile at this point that understanding that in some of these drivers that drive policy, drive action, we need to make sure that rural communities are there. We need to talk about benchmarks, data, and then what we've learned from some of these opportunities. And then, of course, once it's in a plan, so much easier to execute to get funding. Also having our state cancer coalitions really work towards utilization and implementation. And I think, having a firm thing to say like, hey, this is part of our goal in Colorado. This is our strategy. We can talk to policy folks. We can talk to clinicians. We can talk to community. And so it's funny because when although we talk about like prostate screening and all the other screening, especially for hard to reach men, there's interesting ways that I think we've learned a lot about what helps activate communities and what doesn't, and that everything is not a one size fits all. And then I think understanding from that, helping build plans, helping develop sort of this work. And I think for navigators, particularly understanding what are those barriers and what are those opportunities. And then also then again, creating kind of a large network for thinking about how do we do handoffs in care, transitions in care. But so much of this also is also making sure that especially through palliative care, and then hospice even, not that they're one and the same, how people aren't necessarily only living in front range hospitals and like, how do they come home, right? To be supported by family, by friends, how do navigators play a role? And so as you were saying that, it just made me think about, all the ways that we build that into our plans and really think about that directionality of all of us working together. And then from those communities, what are strengths, but then how do we really bridge? But we do that a lot through Comp Cancer, Cancer Coalition, and then again, those networks that have built specifically for navigators. But it's funny because you're right. How to meet people and where people gather and convene are very different in all parts of Colorado, but rural definitely has a different jam than the Front Range of Denver and Colorado.
Yeah, and if I can, just one more thing, Lisa, if we have follow-up questions or if we want to introduce our next speaker. But if you missed it, because sometimes I need to have the obvious pointed out to me, but you are all wise individuals. Patient navigation is absolutely a key strategy that your program could be utilizing to increase and improve your workforce, your workforce struggles that you have. It is not the end all be all. It is not the solution it is a part of a multifaceted solution to keep your navigators trained,
Mhm.
thriving, engaged, and networked is absolutely a one tactic that your program can engage in, implement, or really refresh if maybe you wanted to do that and just lost that effort. I look at Andy and her work as almost like one of the founding godmothers, because GW uses so much of Colorado's the training collaborative. We use so much of their original work in our training that it's just easy for us to go, oh, patient navigation is a strategy to be able to improve a workforce shortage that you have across your state, because those navigators, if networked well and thriving, can really help to link the resources all across your state, no matter where they are, to be able to be aware, to be able to discuss things with your patients and know the lay of the land. You don't have to
Mhm.
have, it's kind of like having eyes everywhere
Mhm.
without your coalition or you. If you're listening to this and you're like, I am one person who's running my entire state Department of Health. We see you. Lean on programs like navigation to be able to implement what you can in your state to be able. And Andy, correct me if I'm speaking out my, the side of my mouth, but I feel like that's strongly something I'm passionate about and thankful for your work, Andy, and what you've done in this field to make it a strategy to lean on and say, hey, navigators from end to end across the spectrum of the continuum absolutely can address workforce shortages. Again, it cannot fix it. It is not the solution, but it absolutely is a piece of the puzzle.
Yeah, and I would say, a 100%. And I think, it's funny because we also have people that are EMTs, right? That serve and help do navigation or community outreach and engagement. And so, I think there's a lot of different ways that we develop, and navigators can be a part of that solution in that, sometimes folks are already in the community, working with the community, doing a number of things. I think there are people who often in rural communities that we work with that also like take on the function of doing some element of navigation or community health work. And we think about that extended workforce. And so, I do think that there's a lot of different ways, that we've been talking about this work. I do think the other thing that you mentioned, Kelly, is like one of the things that we also talk about is, doctors, nurses are great at doing things that are at the top of their licensure, but so many times people who are in the community with community, serving as navigators, they can do so much of the work that offloads really what sometimes acute providers really need to be working. And I think, in Colorado, what we've done is particularly for people who are not credentialed, right, with clinical licensure, really tried to use HRSA grant funding, other types of funding opportunities to say, like, look, if your jam is really working in and with your community to reduce barriers, increase access to care, and that's really where your passion is, and you have an aptitude, right, to understand about cancer prevention, control, or other chronic conditions. One of the things we've tried to do is also grow, right, the workforce in those communities to say navigation or community health work might be right for you. And then to your point, we really do try to make sure that there's resources then for them to go through training to get that credential to sit for our statewide credential and then really have what we consider to be a professional navigator degree. But I think that way, even a lot of times within that workforce shortage, we're identifying because so many of these people are already sort of like natural navigators already, right? They're just not being seen as that. They're not sometimes employed. But I think it's also then, when we think about team-based care, and I'm talking about in the community, clinically as well, the team can also include people who are what has classically been called lay health navigators, right? Which we're now referring to as professional navigators because they are people who are licensed. They all are looking at opportunities. You really can grow. And I think about sometimes in our communities, we know those natural helpers and really thinking about how do we make connections. GW has an amazing online course, has that work. There's other types of courses and the like. And really, I think for programs that are really rural, rural or in certain states, understanding what does it mean to bring people who might not be licensed into having, something more of a formal opportunity to become navigation community health work. It's a great opportunity for many people. And oftentimes the resources are there, or it really might not take a lot of out-of-pocket costs. And so to your point, to grow an extension of like, what is a healthcare team in rural and frontier communities? there's really a lot of opportunities. And then the one thing I'll say, and then I'll be quiet because I know it's someone else's turn to talk and I have to go soon. But I will also say, I think about looking at other opportunities. CHWs, or we've actually started using for those who do have paid EMTs, which not all communities do, or fire, in downtime, doing community checks. So if they've seen someone in the emergency room, utilizing those first responders to come in and do wellness checks on folks, making sure to help that there's some things. We've seen some really unique opportunities where, this extension of those who are doing similar type things or could, how do we kind of multi-purpose and kind of think about moving them into some of these areas where they can do some of this opportunity to really think about helping really ensure people stay out of the hospital, whatever, but get that follow-up care sometimes. So anyway, I really appreciate this. I love GW, all the work that you guys are doing. It's an amazing partnership. And just thank you for all of you who are doing work in these rural communities.
Andy, thank you so much. Thanks for all that information. And again, thank you for taking the time to join us today. Let me just ask, I know, do you need to go right now? Because if so, I just wondered if anyone has maybe a specific question that would be best directed to you, specifically maybe about patient navigation or bringing in the EMTs, the CHWs, while we have you with us.
No,
Your opportunity, everyone.
All right, and I'm going to take April, or sorry, Kelly. I can't believe you call me the godmother of the work in Colorado, but I'm going to take that because
Okay.
it's amazing. Yeah, absolutely. I'm going to do it like sort of like, Godfather more from like the Godfather movies as opposed to
Right.
be, well, yeah, old. But I really love that. I'm going to tell you, I'm going to go tell my husband that you said that because he'll be very excited about it. But again,
Yeah.
thank you guys. And if there's any resources or help that we can provide from our work with in Colorado. I would also say that one other group I would talk about is our state office of rural health, of course, has been a huge partner. So state office at their health department and those who help really connect with the primary care and critical access hospitals. And in terms of us helping really think about what are those issues and to be mindful of like the best way that we grow the work. We've done this through a lot of those sort of statewide rural partnerships too. So.
Yeah, and Andy, thank you so much. And before you jump off real quick, just so you know, in our very first session, we did really go into community health workers, how they can be used and utilized to address just rural education, rural issues, and the people embedded in those communities. Oftentimes, they are called the community health worker role rather than like a patient navigator. You kind of see sometimes when you're already diagnosed and you're in maybe active treatment or you're in that screening process, and that could be the transition between a community health worker and a patient navigator. Those terms are murky, guys, and state to state, it's different. You don't know what you're going to get depending on the state you live in, which is really a hardship for, I think, cancer control in general with screening and then treatment continuum. I think that Andy has some great ideas on that. I look forward to hopefully working with her on that to maybe, I don't know, address clarity one day. The more that we already have, because I feel like this has been a 15-year process to do that. But just don't forget, community health workers transitioning also with patient navigation, key tactic to being able to apply those strategies to your cancer control work in your programs. It's just a win. It's worth the time and effort. And
Mhm.
also, thank you, Godmother. We're so thankful for your time today.
Yeah, I'm gonna get a crown with that, I'm pretty sure. So I think my son has something from Burger King that I can put on or something. So yeah, thank you guys. This has been a lot of fun. I am gonna go off camera, and I do have to jet soon, but I'll stick on for a little while because I'm just also intrigued. Thank you so much for having me. I appreciate it.
Thank you. Okay. So I think next, Anishri, we would love to hear from you about the really exciting work that you've been doing in this space as well. Do you just want to give us a brief background on what you're working on?
Well, I appreciate the invitation to join such an important conversation. And it's really nice to be able to step out of our little bubble of data and computers and really sort of get connected with the real world and quickly realizes that our ideal in terms of our data analysis doesn't always translate in a similar manner when you're working with patients and humans. So I appreciate sort of just being a part of this, and I look forward to an engaging discussion. I have been at GW since 2017. My PhD is in health services research with a focus on health policy. And I'm primarily really interested in trying to understand how the health workforce navigates through the healthcare system, health policies, and yet sort of has to be there, right, as in the front line, delivering care, ensuring that all patients have the opportunity to obtain care and achieve their best health outcomes. I have, prior to my PhD, worked with the American Society for Radiation Oncology, and that's where I did a lot of my primary work in cancer policy. I was leading programs at Astro to develop clinical practice guidelines, and a lot of that was essentially to standardize treatments for radiation therapy for different types of cancers. But I also led, and this was sort of when the Affordable Care Act was passed in 2010, but I led the effort at Astro in conjunction with ASCO in developing clinical quality measures. And a lot of that was, again, to ensure that there was reduced variation and improved standardization in terms of the care that is delivered to patients with cancer. But that was really what led me to get my PhD. To be honest, I was really intrigued by how much influence health policy can have and can impact provider practice patterns, whether it is incentivizing or penalizing. But so that sort of led me to the path of health policy. So at GW, in addition to teaching, my research is focused with the Fitzhugh-Mullen Institute for Health Workforce Equity. And I think, as our name suggests, we do everything health workforce. Our primary goal and sort of our vision is to ensure that our workforce has the courage and the competencies to be able to ensure that all patients have fair and equal opportunities to maximize or have the optimal health outcomes. And so as a part of our sort of endeavor and our focus at the Institute, we look at various aspects of the health workforce in terms of who is a part of the workforce. So if you look at, say, cancer care workforce, what does that comprise of? What is the diversity of the workforce, and how does that have an impact on patient outcomes? We also do a lot around health professions education, because we also take a deeper dive into understanding how the health workforce is trained and how that translates into their practice patterns. And then a big interest of mine, and this is where my research is focused, is really in examining whom does the workforce serve. I heard so much about workforce shortages, and what I'm hoping to do in my conversation with you all today is think about several different dimensions of shortages, right? We often think about shortages in the context of whether the workforce is available, right? In terms of, you saw the HIPSA definition, do we have enough providers relative to the patient needs? And then the other aspect is the distribution, is the maldistribution. We talk so much about rural areas. There are urban underserved areas. And so this, both the lack of availability, which is the actual shortage of the people, as well as the maldistribution, sort of leads to this combination of professional shortages. But what we do in our work is really think about how this availability and maldistribution can be further get really complex as you think about access to care for certain patients is inequitable. And we know, particularly for patients who are enrolled in Medicaid, have significant challenges in terms of whether it is seeking appointments, whether it is being able to have providers that are close to them. And so this is particularly concerning as we are in a policy environment with potential Medicaid cuts, but also that can have a significant impact on not just the coverage of patients and the access to treatments, but also access to providers. And so we like to think about health workforce availability and distribution with this layer of whether or not they are seeing enough Medicaid enrollees, and how does that translate into access to Medicaid patients. So that's sort of where my work is all focused on, with the focus on not just primary care, but also the oncology workforce. And as we move along the conversation, I'll continue to talk tidbits about my work as well. But before I jump in, is it okay if I expand a little bit on our conversation around HIPAA, safety net, and FQHCs? And I would like to talk about it because a lot of this conversation is driven by just how these things are defined, but particularly in the context of the health professional shortage areas or the HIPAA designations, I think is what drives a lot of resource allocation. And I think trying to understand that is going to be really important in terms of what implications it can have in our conversations about the cancer workforce availability and shortages. And so HIPSAs, as Liza, you mentioned, are basically based on sort of these three categories. But a lot of the HIPSAs have focused on designating areas in terms of their shortage for primary care, dental care, as well as mental health. So there is no designated HIPSA for cancer care or oncology. So I just wanted to sort of put that out there. And why is this important? Is because the HIPSA designation is a primary factor that a lot of federal regulations take into consideration as you're thinking about allocating funding. So a lot of the federal programs take into consideration these HIPSA designations as they are making health professionals more available in these areas. One such major program is the Health Professional Shortage Area Physician Bonus Program. And so through this program, CMS, or the Center for Medicare and Medicaid Services, it provides about 10% bonus payments on Medicare services that are furnished by physicians in these HIPSAs. Another program that you may be familiar with or have heard of and is really critical in terms of ensuring that there is availability of workforce in shortage areas is the National Health Service Corps. And the National Health Service Corps also uses HIPSAs. It is essentially to administer federal scholarships as well as loan repayment programs. There is a J1 waiver program for international medical graduates, which allows foreign medical graduates to remain in the United States as long as they are practicing in these HIPSA designations. HIPSA designations are also used for determining funding and eligibility for rural health clinic programs. And so a lot of the safety nets, the rural health clinics are dependent on sort of these HIPSA designations. So as much as sort of, whether we like it, there are several sort of reasons why the existing HIPSAs may need sort of some level of modification. But all said and done, the HIPSAs play a really critical role in how the federal government is investing resources and ensuring resource allocation. And again, we do not have designated HIPSAs when it comes to the cancer specialist or the oncology specialist workforce. I just wanted to sort of plant that seed there, and I'll come back to it in terms of why that's important. The other sort of key things that I wanted to talk about is I mentioned how the federal HIPSAs are used for determining eligibility to assign rural health clinics. I want to note that there are certain states where the state governor or a designee has done sort of their own designation, of a rural health clinic shortage area. They are called the governor designated or the secretary certified shortage areas for rural health clinics. There are very specific states that do it. And to make this easy to understand, I'm just going to put the names of those states in chat so that you all have it. So Arkansas, Iowa, Kansas, Michigan, Minnesota, Nebraska, Ohio, Oklahoma, Oregon, Tennessee, and Vermont are states that have their own designation for the rural health clinics. But again, for the rest of the country, right, they all sort of follow the federal assigned HIPSA designations.
Is anyone
So
impressed that she could just spout that off? Because I can't even remember what all my kids' names are. So
oh,
Dr. I'm
sure,
so
sure. So here is
impressed.
what they're called. I'm gonna again paste that in chat. Um, there you go. So it's the governor designated or the secretary certified shortage area. So just added that to chat. And so in the context of all of this, right, is two key sort of healthcare organizations, institutions that play an important role in trying to bridge some of these gaps because of the maldistribution and the shortage of the workforce. So one such is the safety net. We have already, Liza discussed the safety net definition as sort of as defined by the Institute of Medicine as those providers that organize and deliver significant healthcare and other needed services to uninsured, Medicaid, and other vulnerable populations. So again, this is very close to my heart because of my work with Medicaid patients. We obviously look a lot at the safety net hospitals and healthcare systems. The safety nets are publicly funded, and these are administered hospitals. And again, with any changes in budgets, any changes with Medicaid cuts, can have a significant impact on whether or not the safety net hospitals can remain open and functional. We already have been reading a lot about sort of for the past several years, the challenges with keeping hospitals in rural areas open, and the closure of these rural hospitals can have a significant impact, right, on how much distance a patient has to travel to seek care. And then the other sort of piece that is important in this puzzle of workforce shortage and shortage is the role of the federally qualified health centers, or the FQHCs. These are again considered to be a very important safety net providers, particularly in the rural areas. These are primarily outpatient clinics, and they qualify for very specific reimbursement systems. So they're paid slightly differently than a provider in a private practice in urban areas in Virginia, for example. FQHCs have been really important in terms of providing a very comprehensive set of high quality primary and preventive care, and that is regardless of one's ability to pay. So as you can imagine, a lot of the patients that receive care at FQHCs are either uninsured or are underinsured or are on Medicaid. So they're truly the strong safety net of our nation. The other cool thing about FQHCs is that they really invest in interdisciplinary teams and have patient-centric approaches. Care coordination is a big piece of how care is delivered at FQHCs, but they also work with other providers and programs in the communities, right, to improve access to care and community resources. And I think the role of FQHCs, particularly in the context of cancer care, is important as you think along the cancer care continuum, whether it is from screening, diagnosis, to survivorship and palliative care, right? Or you can imagine how the FQHCs can have such an important role to play for patients along this cancer care continuum. So that's sort of the tidbit about this. One other thing about FQHCs that I find really interesting is that these are community-based and patient-directed. And what that means is that the governing body or the governing board of the FQHCs has to have a majority representation by the patients. And so it is really sort of this patient-centric community needs sort of related focus of FQHCs. And I thought it was really important to bring that into this conversation that we're going to have today in terms of the role of the workforce for cancer care delivery. I'm stop at that and take any clarifying questions before sort of I move on to the next few pieces of our discussion.
Super. Thank you so much. What I was going to ask you first was from the perspective of a comprehensive cancer program or coalition, who would they reach out to partner with in this sort of sphere? And it sounds like partnering, for example, with the FQHCs in your area to make sure they're on your coalition would be a good step.
Yes, absolutely. I think that patients, health policy, coverage is can be really tricky, right? As one sort of receives cancer care. We've talked so much about there's so much work around financial toxicity, particularly for those that have cancer. And I think in that perspective, we're going to have to sort of broaden, right, our perspective of whom do we engage with to ensure that patients can continue to remain engaged with the healthcare system. There is less disruption to care. And if you think about sort of the kind of population that the FQHCs serve, they clearly play a really important role in sort of bridging some of that gap, right? In particularly for communities that have a disadvantage in terms of access to providers. So most certainly, FQHCs. I would also say that because we do not have sort of these designated oncology shortage designations, I think it's really critical that our COP partners engage with community leaders, patient advocacy groups, but also with policymakers. When we often think about cancer care, we're always thinking about these large comprehensive cancer centers, which not everybody has access to. Right. And so being able to sort of truly put forward this idea of are we going to do anything about the shortages of the oncology workforce, right, is going to be a really sort of critical way of engaging with policymakers. And one last plug I wanted to make is I think, and I may be a little biased in saying this, but I think other community partners such as universities, academic research centers can be really important. We're sitting on these large data sets, but truly what is going to be the most impactful is being able to generate the data and the evidence that you would need, right, for your own purposes, for your own workforce resource and planning, whether it is for advocacy. And so being able to sort of have some of these partnerships, right, with universities and academic institutions can also be really critical to be able to produce evidence in order to support policy changes.
Okay, thank you. You know what? I think at this point, just for time purposes, I would like to bring Megan and Sarah into the conversation to talk a bit about their ECHO project. And then hopefully we have a whiteboard activity and we want to get into breakout rooms. So just to manage the time, let's and Megan and Sarah, if you would, like to introduce yourselves, and Anushri, we'll circle back to continue the conversation. So thank you for sort of laying that groundwork for us. Megan, Sarah?
Good afternoon, everyone. My name is Sarah Gingrich, and I'm the Coalition Coordinator for the Partnership to Reduce Cancer in Rhode Island. And Megan, if you want to introduce yourself.
Yeah. Hi, everyone. I'm Megan Daniel. I'm Executive Director of the Partnership to Reduce Cancer in Rhode Island. And I know Sarah's put together a nice presentation about our Project ECHO, so I'll let her do that, but we're both here and able to answer any questions or explain them.
Yeah, so to start, a little bit about the partnership. So we're a nonprofit organization and the State Cancer Coalition for Rhode Island. And our mission is to lead and collaborate on efforts to prevent cancer and improve the quality of life for Rhode Islanders living with cancer through education, advocacy, and supportive resources. And we started our Project ECHO series. It kind of started, I think, like February of last year. Our project manager at the Department of Health was invited to be a mentor for one of the projects and was kind of like, hey, you should try and register for one of the other projects. Definitely aligns with the work that we're trying to do. So we registered to participate in the project titled Using Project Echo and Patient Navigation to Improve the Health and Wellness of Cancer Survivors in Rural Communities. And the Scaling What Works team hosted a fantastic in-person symposium for us in May of 2024, where we got to learn from some others that were already implementing echo-based initiatives. The Nevada Cancer Coalition was kind of one of our mentors, but we also benefited from connections with other coalitions who attended, and they were all in various stages of the planning process. So it was just incredibly helpful to, get their insights as we were just beginning our project. And like Liza kind of mentioned at the beginning, Project Echo is a virtual learning model that uses expert-led sessions to share knowledge and improve outcomes. And we kind of identified like two key reasons for launching the Echo series in our state. First, there's currently no cancer-specific trainings for community health workers in Rhode Island. And second, we saw Echo as a sustainable, like partner-driven model. So Megan and I are the only two full-time staff members. So we needed something that was scalable and collaborative and designed for like long-term growth. And our goal in our project was to increase access to patient navigation services in geographically diverse areas by training CHWs with tools they need to support Rhode Islanders. In the community. So we kind of equipped CHWs with practical tools to address screening gaps, financial barriers, care coordination. So a lot of things that just align with our mission and the state cancer plan. But I think the hardest thing was kind of bringing the project to life, and we really needed a strong planning team. We presented our concept to our prevention, screening, and early detection work group and kind of formed a subcommittee dedicated to planning the Echo series. We had members from the Department of Health, the American Cancer Society, the Rhode Island Public Health Association, and the Rhode Island Health Center Association. And then the Scaling What Works team also provided really helpful planning tools, like an implementation planning work document that kind of helped us define our goals and track our progress. I will say another thing, securing funding was also very helpful. So we supported the project through a mix of grant funds and some contributions from our partners. So then it was kind of time to lay the groundwork. Our first step in our like implementation plan was to partner with an already established Echo hub. So the slide that was shared earlier about like the super hubs, you can become a super hub, but it's a lot of training and work. And Rhode Island is already a small state. We're a small team. So it just made sense to kind of partner with an already established hub to host this project. So the Brown University Department of Family Medicine is a super hub. So they helped provide like technical support. They gave us access to their iEcho platform for all of the registration things, and also shared some really helpful training materials with our team. So identifying like the right partners was from the beginning was just like super crucial to building a solid foundation and launching a successful series. And then once we had like our partners in place, we kind of turned to content development. So we started off by reaching out. We have connections with all of the cancer centers in Rhode Island and found that all of them have some sort of patient navigator or a similar role they use to support patients, but they weren't really doing any like community facing roles. And some of them didn't even know what community health workers were. So that kind of helped us narrow down our targeted audience for our needs assessment. So we reached out to CHWs, navigators, and social workers to kind of identify gaps in knowledge and training priorities. So our series offered a very broad overview of core cancer navigation themes like care coordination, understanding cancer types, patient communication, and managing financial and insurance challenges. And yeah, Megan said in the chat, I forgot, we also reached out and connected with our FQHCs in the state to have their insight in our needs assessment. So we just wrapped up our final session last week. So we're kind of still figuring out our next steps and kind of reviewing the evaluation summary, but we've already seen some like super exciting outcomes. So looking at our attendance, a majority of our participants were CHWs, nurses, and patient navigators, which was the exact professions we were hoping to engage with. And then looking specifically at our participation data. So we focused our ECHO on Rhode Island specific topics. All of our speakers were from Rhode Island, but we opened a registration to the surrounding region and broader. And we had over 90 people register, which was crazy. But our live attendance audience was much smaller. So we had an average live attendance of about 23 participants per session. And those attendees came from 18 different states and 35 unique organizations. But looking at just the Rhode Island data points, it was really encouraging to see that engagement. We had 27 Rhode Island-based professionals participate live in at least one session, and they represented 18 different organizations, including FQHCs, community health centers, nonprofit groups, and local service providers. So many of these organizations that we connected with were entirely new for us. I think a majority of our content experts we had never worked with in the past. So that was just like a significant milestone for the partnership to broaden our connections in the cancer community in the state. So it didn't just help us like expand our network, but it also did the same for other local organizations to like connect and collaborate with one another. And it just was a great platform for organizations to share their knowledge and build relationships and engage in cross-sector conversations, which is the whole point of Project Echo. So yeah, it was just like really important for us to build those connections and eliminate the siloed work that's happening in the state, and build workforce capacity. So we kind of learned the main thing from this Echo series is that collaboration is key to maximizing impact and building workforce capacity. We would not have been able to do it without our partners and without Brown and all the people on our planning team, especially just with Megan and me. It just wasn't sustainable for the two of us to start a project, and we're hoping we can continue to do this and have other series. And this was a very broad cancer topic, so start doing some echoes that really dive deeper into other topics that people are interested in learning about. So, and I think this our website was in the chat, but I can drop our link to our Project Echo site. So all of our echoes were recorded if anyone is interested in watching those or reviewing those as well.
Terrific. Thank you so much. Although now it sounds to me like you guys are ready to be the mentors.
Maybe. We'll see about that, but we could definitely help. But yeah, working with others is definitely the easiest way to make something happen.
Okay, thank you. Kelly, I'm thinking for time we should go directly to our whiteboard.
Yep.
Okay.
Yeah, that sounds great. And I would say if you have questions for Dr. Anushri, for Megan, or for Sarah, pop them in the chat. But we're gonna we want to do some interactivity, especially to apply what we just heard about workforce shortages and really digging into the data in your, because we do a lot of data, right? Data mining for screening, mortality, incidents. Our registries work a lot with that. But we have a lot of data that we actually do have at our fingertips. I correct myself. It's not a lot. We have some for workforce shortages. So I'm going to share, if it's okay with you, Dr. Fakari, I'm going to share the website and walk us through an exercise. But I do want you to jump in and correct to be like, hey, remember, this isn't going to give you exactly what you're looking for. So I'm going to pull up a whiteboard, guys. Tell me if you see it, don't see it. We're going to take 3 minutes, Lisa, if that's okay. It is quick. It is quick. Let's see. Oh, actually, you know what? Lisa, I developed it in the GW. So if you could go, I'm going to have Lisa share it. Click on your whiteboards, Lisa. And then you should have the GW Rural COP whiteboard that's an existing whiteboard.
I should.
If you don't, I mean,
it wants me to sign in to save my work, and I'm going to try to do that, but
Hmm.
It has not, let me see if it's gonna let me. See, that's complicated.
Hmm.
Oh, I know what I need to do. It's just gonna take me a minute off.
And let me know if I can pivot and sorry guys.
No, it's just a matter of
Oh, you know what? Hold
right.
on. Let me try something. Okay. So this might work, but because I'm in a Zoom meeting, no, it won't work. Oh, wait, maybe. So does anyone, if you can click on that whiteboard, let me know if that works for you or not.
It works.
Okay. I need you guys to be able to edit it though. So 1 second. Let me jump back over to my other whiteboard. You can edit. There we go. All right. So, um, if you guys, this is a map of the United States, but sorry, I'm stating the obvious here. Long day. If you click on that link there at the top, that is the HRSA data, and open that link. What we are hoping that you can do is just take a couple minutes. It says 5, we're giving you 3 just to be able to make sure we get everything in before we can send you off well today. And I want you to, if you can, in the find shortage areas, you're going to click on search HPSAs and then do your state, tribe, or territory. So I I don't know if it would serve you guys well if I was showing my screen while I was doing it. For example, I live and work in Iowa. So when I search Iowa, I see all the counties pull up. And I do notice that I can apply those filters that we heard about earlier, the primary care, dental health, or mental health. So dental health obviously could apply to oral head, neck, things like that. Those providers are really important. If you're focused on head and neck, that would be great to see where your shortages are at. Primary care is also, a whole different area that you could be focused in. And mental health, obviously, for psychosocial support. So this is beneficial across the cancer continuum. For today, I'm just going to have primary care clicked. Now, it should pull up all your counties. You can click on the columns to be able to sort your counties by the HPSA score. So, what I want you guys to do, just to be able to kind of be familiar with this, is to sort that score based on the highest score at the top. And then on the map, on the whiteboard, place a sticker, place a star, place anything that you'd like to about where or what county are you seeing come up the most. So I'm gonna have to zoom in really close on my map. I don't think you can see, I don't know if you can see my screen, but I've already done this. And do you guys see Des Moines County is right there in Iowa? I can't see your faces, so someone tell me yes.
Yep.
Yeah. Okay. Thank you, Zoe. So Des Moines County is one of the top ranking counties as far as listed as shortages, which is surprising because it is rural, but there's some metro areas in Des Moines County here in Iowa. So we're just gonna take a couple minutes, find your state, find your county that has one of the top ranks of having a healthcare shortage. And I'm just curious, while you guys are doing that, is there anything that you have to add, Dr. Fakari, that you want to add? This is your
Sure.
baby.
Yes, the only thing I will add is so some of our current funded work, what we're trying to do is take these designations a step forward and enhancing it. So, one of our projects, which is funded through a pilot funding at GW, We are actually leveraging the Medicaid claims data. We have national level data for over 5 years now. And so we are using information from the Medicaid claims data, such as diagnosis codes and procedure codes, to really hone in to the specialty of the oncology specialist. So we're not only identifying whether or not a physician is a medical oncologist, we are enhancing that specialty identification by seeing the patient panels and knowing is this a medical oncologist that primarily treats breast cancer? We found some really interesting patterns. Our paper is actually just got notified yesterday, has been accepted at the HSR journals. I'll be happy to share it once it is in the pre-publication preprint. But what we found is that not a lot of times does the certification or licensure truly reflect what the physicians are doing. And this is really important. So, for example, we use licensure data to identify physicians who are dually certified in medical oncology and hematology. And what we found is for these physicians, for about 30% of them were exclusively seeing breast cancer patients. Now, some of it could be reflective of the fact that we were using Medicaid data. And so we may have different practice patterns if we were including commercial claims or Medicare. But why is this important? It's because when you think about the availability of the workforce, it's not just to ensure that you have a medical oncologist, right, in a particular county or in a particular zip code. It's important to know what are the kind of cancers, right, that this medical oncologist, for example, really treats. I shared a link to our Medicaid workforce tracker. It's an interactive dashboard that we've developed using the Medicaid claims data, which essentially gives you a way to identify. So similar to what exercise that we're doing now, you could do the same to try for your own state and county to know how many primary care providers actually see or participate in Medicaid. We're now expanding that to include the Medicaid participation of the oncology specialist workforce. So the data like this, right, will be really critical in terms of enhancing the specialty designation. So that's sort of what I wanted to add in terms of what's in the pipeline and sort of how this exercise is really helpful. But this picture, right, in terms of designation can look very different once you start layering it in whether or not Medicaid patients actually have access to these providers.
Thank you. And congratulations on the paper. I would definitely, once that's in pre-publication, if you would share that with us, that would be terrific.
Thank you.
Okay.
Can I add one other point as we're seeing this? One of the things you may have noticed as we were defining is this is all about the physician availability. There is an increasing workforce, right, of advanced practitioners. And so including nurse practitioners and physician associates, which again is a growing workforce, whether it's in primary care, whether it's in oncology, they are not taken into consideration when the designations, the shortest designations occur. So one is sort of that caveat. And as we're thinking about this in terms of access, the role of telehealth, right, it can be particularly important. Of course, there are digital deserts and rural areas may not always have access to telehealth, but those are some of the caveats that I wanted to put forward as we are thinking about the shortage designations.
Thanks.
Sorry, guys, I'm learning a lot about what sharing opportunities I have with the whiteboard. So I'm going to put the link in the chat. And I want you guys really to just know this tool is out there. How I envision a tool like this working, so reporting back to CDC and your work plans or working with your work groups is that ideally you could identify a handful of counties that you see as having these initial workforce shortages, knowing that the data is not perfect and not prescriptive to being exactly what might be short for, what Dr. Vakar just said. However, it's a data point you could absolutely include in your metrics of, hey, we have identified based on the information we have today, these are the counties that have shortages and are able, we maybe could get a meeting together with them. That is an activity that you can list as a metric in your work plan back to CDC. That is a coalition tactic, an activity that you could absolutely coordinate. You're not fixing the problem of workforce shortage, but you are being a convener of maybe a group of counties or a region to bring them together to have a conversation to address, hey, what's actually going on in this area of our program, things like that. So I just wanted to make sure that that was crystal clear, as why we're talking about this, why we had you guys do this map. And again, pointing it back to how can this be a tactic that you guys are using in your both your CDC required work, but also in your state cancer plans and working with your coalition and partners. So I hope this was helpful. And thank you. I know there was conversation in the chat of explaining. Oh, wow. Thank you. You did such a good job explaining that. Julie, did that answer your question? I know you're probably still reading through it.
Yeah, Julie says, yes, thanks. Terrific. All right, Kelly, thank you so much for sharing that. We have about 10 minutes left. What I'm thinking, Kelly, if this sounds good to you, is just having a discussion right here as opposed to taking the time to move into breakout rooms. We have some questions that we were suggesting, and I'm going to share my screen real quick.
I feel like if you get to the end of our community practice session and you're still here, you should absolutely get like a Starbucks gift card. So thank you guys. I know it's late in the day. I really appreciate those who could stay on with us.
Yeah. So these are the questions we're suggesting, after, well, obviously, if your cancer plan is addressing workforce shortages, that wouldn't have changed in the last hour. But does your cancer plan address workforce shortages already? Are you working on any specific activities yourself in your program or coalition to address shortages? And if you are, how's it going? So those are the questions we wanted to throw out. Certainly, if anybody has a question, either for Dr. Bachari, for Megan, for Sarah, please feel free to either come off mute or to drop that in the chat. And I'm going to stop sharing just so we can see each other, because I'm going to put those questions right into the chat.
I'm wondering, is it okay if we just stay in one room instead of doing breakouts?
Yeah, I think we should just stay right here.
Okay.
Exactly. Hey, Kara. Hi, Kristen. Do you have a question?
No, I actually had a comment. So we're actually in the middle of doing our cancer plan right now, and we do have workforce objectives in our plan, and we actually included workforce objectives in our last plan. One of them was to increase the number of APRNs practicing in the state, and there shortly after our plan went into effect, there was a bill that went through our legislature, which only meets every 2 years for like 3 or 4 months. It's really sad. But so it takes a long time to get policy passed. But there was a bill that we supported to increase licensure for APRNs. And we blew our objective out of the water. It was crazy. It's insane. We have so many APRNs now. I think it's one of the only areas where we do not have a healthcare provider shortage in the state. Like almost every provider type, aside from like anesthesiologists and APRNs, is short in Nevada. And so we've got new objectives this year to increase licensure and practicability for PAs and genetic counselors. And so we're hoping that that increases those as well. And then fortunately, we're lucky to have a senator who has been working a lot to expand like rural workforce programs for healthcare. So, but yeah, I think policy wise, that's an opportunity for us that we identified. I think other states have better policy than Nevada. So it may not be the best route for other states on workforce development.
Well, congratulations though on that win. I mean, that's
It was huge.
huge.
Yeah. And our next one is pediatric workforce. Most kids have to leave the state for cancer care.
Good luck.
I can chime in just a little bit. So this is a great topic, and I'm really glad that we're talking about this because it's sparking a lot of things in my brain. I'm with the Louisiana Cancer Prevention and Control Program, and we are in the very beginning of starting a program where we're working with community health workers kind of already established in communities to build up their capacity to do some education around cancer, and then have having them connect the community members they're working with an virtual patient navigation, centralized patient navigation program that we have some nurse navigators here in our office who are on the other end of that, and they're meeting with people one-on-one and then trying to find them the closest care for whatever their medical needs are. Very early, very ambitious. The more we get into it, the more we realize we have a lot more to learn. But as I'm thinking about that and kind of how that could, good to know Nevada Thrive. I will look into that. Thinking about the workforce development piece of it, I am now flashing back to a meeting that I was at that was sponsored by one of our big health systems. And the whole evening event that they had was on workforce development. And they were talking about this kind of pipeline project that they had of really helping to get people in as, kind of, I heard someone say not lay, but professional health workers or navigators, and then kind of getting them into a training program and then, kind of working their way through that. And so now I'm thinking, that could be an interesting partnership to look at what opportunities might be there to working with this larger system. We've already reached out to some people to help with more training for the community health workers we're working with, and just some more support. I definitely, Sarah, I looked at your echo because we're hoping to do that same echo, depending on what happens in the world. We also applied to do a very similar project here in Louisiana. So I got that website and we're going to be looking at that. But anyway, this conversation has been really helpful and I have a lot of great ideas. And thank you, Kelly, for sharing some of that information. So I will be reaching out to Kristen. So awesome.
Terrific. Oh, we're really glad to hear about the connection. So thanks for letting us know. I'm so sorry to cut this so short, but we only have just a few minutes left, and we do have a really brief poll. For those of you who have stuck with us, it looks like, can you see it? If you, it's just 2 questions, but as always, we would appreciate your answering those. And while you're thinking about it, I'm just gonna tell you and not bother showing the slide, that our next session is June 25th, and we are going to be talking about policy. So we hope you'll be available to join us. And I'm going to introduce you to Gracie, Gracie Angel, who's a family member for 3 days.
Yes. Yep. This is our Australian Shepherd puppy, also known as a shark. So for a bonus for you guys for sticking on and doing our poll, yeah, she is a puppy shark. It is absolutely in that season of just put a toy in her mouth and she'll lose her teeth eventually. So, yes. I figured at the very end it could be a bonus while you guys are filling out your poll. But I told Lisa at the time, I was like, I've got to kennel her because I cannot have this meeting and focus and also have her roaming around. I don't know if you guys have ever had a puppy like that.
Should not have been a mature participant in our conversation.
Yeah, so Julie, are you glad that you got the dog now? Did you survive?
Um, I guess my husband's still not happy that we have the dog. It made dog number 3, and that pushed us over. I should have probably stuck with 2.
This is our only one. Well, we lost our other one in December. So this is our new baby in the house. So
Oh, fun. Yeah. Yeah. It just happened to, wasn't looking to get one, but they're fun.
fun.
Yeah. Yeah.
I'll let you know in a couple months if fun could be
Yeah.
categorized in a different way.
Yeah. Anushree, thank you. Anushree just noted she was happy to hear about the role of CHWs and patient navigators, and she's added her email to the chat. Thank you so much. And thank you, Anushree and Megan and Sarah, for all the information and for your time this afternoon. And if someone happens to send us a late breaking email question, we'll get in touch. But as always, we'll be sending the link to the recording and a list of resources from today's session just in the next few days.
Thank you for having us.
Yeah.
My cat got jealous and heard, so she came to say hi as well.
I've been seeing your cat's tail go
I
across
know.
the screen the entire meeting, and I love it. It's
She's
nice
so
to-
obnoxious. She loves the attention.
Yeah, and a stray mama kitty just brought us 3 kids. Brought us? Like, brought... Oh, goodness.
You're blessed. Cat distribution.
Yeah. Yes.
Yeah.
Yeah.
Distribution method is in full effect. We're probably keeping the mama. So if anyone would like 3 little kittens, we have them.
You're a little far from us, but best of luck.
Right, y'all. Thank you so much for being with us and sticking around till the end. We do appreciate you, and thank you for your time again, Anushree, Megan, Sarah.
Thank you. It's
Thank
been
you
a pleasure.
again.
Yes. Thank you, presenters. We so appreciate your time today.
And thank you for answering the poll, you all.
Bye, everyone. Thank you.
Bye. All right.
So we still